I am probably overdressed. I just looked at the weather for today. It was nice and chilly this morning, so I have my Alaskan Brewing Company hoodie on, but it's supposed to be 63 degrees today. So right now it feels nice and cozy. This is a great beer, the Alaskan Brewing Company. You can only find it in Missouri and St. Louis, Kansas City, and now in Boonville, Missouri. So, if you haven't tried Alaskan Brewing Company beer, it's worth your time. Okay, so there's my plug. And Alaskan Brewing Company has nothing to do with helping me out doing these. Okay, so we were talking about the Women's Health Initiative. I think it was Monday, and the fact that a huge drop-off in hormone replacement therapy happened because of the publishing of a front page story on the USA Today that hormone replacement therapy, and they specifically said estrogen, and then didn't explain that, caused an increased risk of heart disease, heart attack, and breast cancer. Morning, Eileen. And so we talked about that because they were studying conjugated equine estrogens and a chemically altered progesterone molecule. So this week in anatomy and physiology class for my students, we are talking about reproductive system, and we spent a lot of time talking about estrogen, not necessarily estrogen and hormone replacement, but what estrogen does in the body, what progesterone does in the body, and the different types of estrogen. So the first thing we're going to talk about is the different types of estrogen. Okay, so the reproductive age from the ovary estrogen is 17-beta estradiol. I think I mentioned that Monday. There's two others. There's a weak estrogen called estrone that's made in peripheral body fat, and it's a paracrine regulator. So estradiol, there's estrogen receptors all over your body, including your cardiac muscle cells, or your cardiocytes, but there's estrogen receptors everywhere, liver, bone, etc. So 17-beta estradiol is a natural estrogen produced by the ovary for the most part. And then there's peripheral conversion from androgens like DHEA and testosterone that can be converted to estradiol, estradiol and estrone. Hey, Linda. So that estrone is the major natural hormone of women past menopause. It's made in peripheral body fat because estradiol is no longer being produced by the ovary. And you can prove that by measuring the level of estradiol. You can measure estrone, you can measure estrogens, but usually I'm looking at estradiol because a reduction in estradiol is what causes that famous hot flash that 99% of women who are perimenopausal and menopausal, that's their main complaint. I'm hot flashing. I can't sleep. I'm too hot. I open the windows in January. I have a fan blowing on me all the time. Okay, so the third estrogen is estriol. It's made in the placenta, usually the most at about 20 weeks, but it is also active in the third trimester. So you don't really make estriol unless you're pregnant. The fourth kind of estrogen we're going to talk about is the synthetic one, where all these little recommendations or not recommendations come from. I reviewed all these different things. The FDA, ACOG, the American Congress of Obstetricians and Gynecologists, AAFP, the Family Practice Group, does not have a recommendation. They defer to ACOG. Not really anything from the CDC. American Heart Association is kind of on the fence a little bit. But the Women's Health Initiative was based on treatment of women who were, on the average, about 13 years past menopause, and they were put on conjugated equine estrogen. So it's a bioidentical hormone for horses. equine estrogens. So that is the vast majority of the estrogen replacement that's been prescribed. I told you that Premarin, conjugated equine estrogens, was at one time the most prescribed medication on the planet. There were more prescriptions for Premarin than anything else. So conjugated equine estrogens are not human estrogens. They're equine estrogens. And then Provera is medroxyprogesterone acetate. So there's a progesterone molecule in it, but it has a medroxy group and an acetate group on it. So it's synthetic. It's known as a progestin. And virtually every study that I read talked about conjugated equine estrogens and Provera. There's more than one synthetic progesterone or progestin, sorry. So chemically altered progesterone. So what we're going to talk about is there a primary protective effect for estrogen? So I told you I used to tell students at the University of Nebraska, the medical students, that based on Premarin, there seemed to be a cardioprotective or a heart protective effect of estrogen. So over the last 4 decades, so we're going back, we'll say 1980-ish. Now the Women's Health Initiative was an NIH-funded study, National Institute of Health. It was halted early because of an increased risk of heart disease and pulmonary embolism and breast cancer, specifically in the Prem-Pro group. So that would be Premarin plus Provera. So they used the actual step, Prem-Pro and Premarin. There's 2 arms, 160,000 patients. So over the past 4 decades, there's been a sizable amount of research that shows a relationship between hormone replacement therapy and cardiovascular health in postmenopausal women. So the #1 killer of women in the U.S. is heart disease, heart attack. I mean, cardiovascular disease is the #1 killer of Americans every year. Okay, so the question is, if someone is on hormone replacement therapy, does it provide protection? Well, in the 1980s, observational studies revealed that postmenopausal women on hormone replacement had a lower risk of coronary heart disease and death from all causes. And then comes the Women's Health Initiative. So in 2001, this was randomized trials versus observational studies. And the HERS study that I mentioned Monday, that failed to support the suggestion that hormone therapy after menopause protects against heart disease. So that was a randomized trial, so it was overshadowed. But it was a randomized trial on conjugated equine estrogens. Okay, so if you look at that, like I told you Monday, the mean age in the Women's Health Initiative trials was 63 years of age. So those women, mean age of menopause onset is 51.4. I told you Monday that hasn't changed for years. So we'll say 51, 63, so 12 years past menopause, okay, is when they were starting hormone replacement with conjugated equine estrogens. Well, I also told you that I taught in 1990 that women past 50 not on hormone replacement therapy start to have a higher risk of heart attack and heart disease by the age of 65. So at 63, if that was the mean age of starting hormone replacement therapy, you would expect an increased risk of heart disease and heart attack in those women because they were already 12, 13 years past the age of 50. Okay? So comparing the randomized trial to the observational studies that included mainly younger women, that suggests that the timing of the onset of hormone therapy with respect to menopause onset and the age of the woman at the start of therapy might explain the inconsistent results of earlier studies that showed that hormone replacement was protective as far as heart disease and heart attack. So that's called the timing hypothesis. So that asserts that the initiation of hormone replacement therapy within a few years after menopause, and they're still talking about conjugated equine estrogens. We'll get to the estradiol part here in a little bit. So women's hearts are younger at 50 than they are at 63, and their coronary arteries are more receptive to the beneficial effects of estrogen, and that may reduce the risk of heart disease. So there's been some head-to-head studies that showed that initiation of therapy later in menopause, specifically 6 years past menopause, there is no cardiovascular benefit, and that may even be harmful, which is basically what the Women's Health Initiative said, but they were 12 years past menopause, right, on average. So we're talking about their mean average start of hormone replacement with equine estrogens and synthetic progesterone, so synthetic progestins, was 12 years past the mean age of onset of menopause, which is 51.4. Okay, so finally, this is from 2016 New England Journal of Medicine, was the ELITE trial, E-L-I-T-E, which stands for Early versus Late Intervention Trial with Estradiol. And I just told you that estradiol is the human estrogen from the ovary. Hey Jesse, nice to see you. I haven't seen you in so... I follow you. I see what's going on with you. So I'm paying attention, just so you know. So the ELITE trial showed or demonstrated that women who received estradiol, not conjugated equine estrogen, so estradiol rather than placebo, so it was a placebo-controlled randomized study, had lower risks and rates of subclinical atherosclerosis progression, but only when that therapy was started within 6 years after menopause. Now, I would argue that that's even too late, because if you're perimenopausal, let's say you're 48 and you have menopausal symptoms, but you're still menstruating, and you have abnormal, suboptimal levels of hormones during your menstrual cycle, then you would benefit from supplemental estradiol, especially if you're hot flashing. So when I was in practice, it was always a combination of estriol and estradiol. So when I work with my collaborating functional medicine doctors as a health coach, for the most part, we're using a combination of 20% estradiol and 80% estriol. Okay, so healthy postmenopausal women in this trial without diabetes or evidence of cardiovascular disease, so they had no cardiovascular disease that they could demonstrate. There were 643 women in this trial that participated in this study. None of them had had regular menstrual cycles for 6 months. They had not had surgically induced menopause, and their estradiol levels were less than 25 picograms per milliliter. And I told you Monday, if you want to diagnose menopause, you do an FSH level and an estradiol level. And if the FSH is over 40 and the estradiol is less than 40, you have menopause. I was taught that by Panjola Coney. She was my mentor at the University of Nebraska back in the 80s. So she taught me that if you want to know if somebody has menopausal syndrome or menopause, the diagnosis, FSH over 40, estradiol less than 40. And that was based on a reproductive endocrinology textbook from years ago. Okay, so in a 1-to-1 ratio, These women were randomly assigned to receive either oral 17-beta estradiol at 1 milligram a day or placebo. Okay, the women who had a uterus also received 45 milligrams of progesterone as a 4% vaginal gel, which was administered sequentially, so once a day for 10 days of a 30-day cycle of treatment. And then in a similar regimen, the non-estradiol group, so those not receiving actual estradiol, received oral placebo and a placebo vaginal gel. Okay, so this was double-blinded and randomized. And then they were stratified into two groups based on the number of their postmenopausal years. So the younger group were less than 6 years from onset of menopause. Okay, and then women who were postmenopausal for greater than or equal to 10 years were put in the late postmenopausal group. Okay, the early menopausal group median age was 55 years. The older late menopausal group was 63.6 years, so the same exact year as the Women's Health Initiative. So they looked at a baseline carotid artery intima media thickness, or CIMT, and they looked at history of hysterectomy. Okay, the mean carotid artery intima media thickness was 0.75 millimeters in the early group and 0.79 millimeters in the late group. The ideal CIMT media thickness is 0.5 millimeters or less, so they were a little bit over that. Okay, so the rate of change in that media thickness of the carotid artery was the trial's primary outcome. So it was assessed twice at baseline, an average, and then every 6 months during a follow-up for a median of 5 years. Okay, so they're looking at these people and what they didn't do is check their hormone levels. So I would kind of fault that. So the results indicated that the ones that were on estradiol compared with placebo had less progression in their carotid intima media thickness in the early group, but not in the later postmenopausal group, the older group. Okay, so significantly lower using estradiol. Okay, there was no benefit on secondary outcomes of estradiol therapy. So they measured CT measures of coronary artery calcium, and I told you about that Monday. You can do a CT cardiac calcium index. Total stenosis and total plaque in either group, and that had nothing to do with whether or not they received progesterone. Okay, they were only measuring 381 women because they decided to add that CT measure of coronary calcium index score after the trial was extended. Okay, there was no significant difference in the frequency of adverse events between the placebo and estradiol group in either the late or earlier menopausal group. Okay, so basically they were looking at carotid intima media thickness. Okay, so what's the chemistry behind estradiol and its benefits? Okay, so I've had a lot of sort of arguments, academic arguments, I guess, with people, clinicians that think that oral estrogen and hormones in general, hormone replacement therapy, is kind of a bad idea. But there's some evidence on going through the liver, so estradiol that's taken by an oral route, if it goes through the first pass mechanism through the liver, the cytochrome P450 system, that is what seems to help with cardiovascular protection. I'll ferret that out a little bit. I'll ferret that out. I got to research that a little bit more, and that information is actually from a physician friend of mine. Tammy, yes, women that are on estrogen do seem younger. I always tell the story of this woman that used to work at in Clinton, Oklahoma, at the Route 66 Museum. She was 89. She looked like she was about 60. She was on hormones. I treated her when I was out there. But the women that I have treated as a practitioner, and now people that I collaborate with who are functional medicine doctors who understand hormones, and I'm health coaching them, those women do feel better, and they feel stronger, and they feel younger, and they don't look as old as some of them, some of the people that aren't on hormones, because they're scared. Okay? So I'm going to give you some information from the Cleveland Clinic. So the Cleveland Clinic is kind of the Cleveland Clinic, right? Okay, so what does estrogen do in your body? Well, we talked about this in physiology yesterday. So studies show that estrogen affects almost every tissue in your body, specifically what people think about as bones. Okay, so it has to do with closure of the epiphyseal plate in young women. When they start menstruating and making estradiol, that has a positive effect on bone. You're growing. Okay, young women are growing. Men still need estradiol. I mean, the guys that I treated are like, ooh, I don't want to have estradiol and grow breasts and all that. And I said, well, if you don't have estradiol, your bones aren't going to be as strong, and you might get osteoporosis, etc., etc. So what does estradiol do in your body? There's a positive and a negative effect of estradiol. So it increases HDL lipoprotein. Okay, it decreases LDL, low density lipoprotein. Now here's where the controversy comes in. It promotes blood clot formation, but there are some changes that have the opposite effect, and we'll talk about that. The next thing is related to that. So I was reading a guy that was involved in the Women's Health Initiative and the HERS study, HERS, and he, in not quite the same paragraph, but one paragraph after another, he said estrogen increases deep venous thrombosis risk. And he's talking about conjugated equine estrogens. Remember, HERS and the Women's Health Initiative is on Premarin, or its generic alternative. And then the next paragraph, he says estrogen has a positive effect on thrombosis. Well, it can't be both, right? Okay, so the next part, so promotes blood clot formation, and specifically that's true for birth control pill estrogens. That is true. But birth control estrogen is ethinyl estradiol. It's not estradiol, it's ethinyl estradiol, so it's chemically altered. And ethinyl estradiol is 5 times more potent than estradiol, so that it can suppress ovulation. You can't take estradiol as a birth control. You can take ethinyl estradiol as a birth control. And some women stay on birth control pills till they're 54, 55, and then they convert to estradiol, hormone replacement. Okay, so why? Estradiol relaxes, smooths, and dilates blood vessels so that blood flow increases. So that's its normal mechanism of action on blood vessels. And what does dilating blood vessels do? They make nitric oxide. So that's a paracrine effect in the endothelial cells of a blood vessel. We talked about nitric oxide before. It's a way to help potentially reduce your blood pressure and potentially reduce your risk of heart attack and heart disease. Well, estradiol stimulates dilation of arteries and nitric oxide production. I could show you a ridiculously complex biochemical equation that proves that. I mean, I teach this stuff, and I had a hard time following this slide. The other thing that it does, estradiol, is it soaks up free radicals. So reactive oxygen species. And what do free radicals do? They promote an immune response and inflammation in your arteries. So this is another, including coenzyme Q10 and glutathione, that soaks up the free radicals that come about from your mitochondrial production of ATP. So it's a normal mechanism, but as you get older, you have less CoQ10, you have less glutathione, and you have less estradiol to help soak up those free radicals, which are running around zapping your arteries all over your body. Okay? So, this article from Cleveland Clinic starts talking about the Women's Health Initiative and the HERS study, blah, blah, blah. And once again, the ELITE study is the only one looking at 17-beta estradiol that I've found. I'm sure there's more. But researching for this, I found the ELITE study. So, from the US FDA, the American Heart Association, and the American Congress of Obstetricians and Gynecologists, here are the guidelines for HRT, hormone replacement therapy. 1. Hormone replacement therapy should not be used for prevention of heart attack or stroke, based on conjugated equine estrogen and progesterone evidence. Okay? So, Premarin is bioidentical hormone for horses. Estradiol is bioidentical hormone for humans. Progesterone is not a natural substance. Progesterone is. Okay, number 2, use of hormone replacement therapy for other problems, such as preventing osteoporosis, should be carefully considered and the risks weighed against the benefits. Women who have pre-existing coronary artery disease should consider other options. I agree with the second statement. Osteoporosis, even Premarin and estradiol and Estrogen, which has estrone in it, is FDA approved for prevention of osteoporosis, but they're hedging their bets, right? Number 3, hormone replacement therapy may be used in short term to treat menopausal symptoms, based on the Women's Health Initiative study on Premarin and Prempro. Most of us that have used human estrogens and bioidentical hormone estrogens have talked about the fact that once you're on it, you stay on it for life. You get the benefits of a younger woman. And we'll talk about testosterone in men later at a different class. So women that start hormone replacement therapy around 50, so we'll say 45 to 55, and some even younger, if they will continue to reap the benefits of hormone replacement therapy if they stay on it. If they stop it, the heart disease risk starts up again. Okay? And then from the FDA and the American Heart Association and ACOG, long-term use is discouraged because the risk for heart attack, stroke, and breast cancer increases the longer hormone replacement therapy is used. That's true of Premarin, conjugated equine estrogens, and really, I'm not even going to say that. That's not actually maybe true, because the arm in the Women's Health Initiative that was so detrimental was the one that contained Provera. Provera is the problem. Premarin, I mean, I've written, I think, one prescription for Premarin. That was back in like 1988, before Dr. Coney started teaching me about reproductive endocrinology. So overall, if you started early, so timing is everything. If you're going to do hormones, don't wait till you're 63. You're going to have trouble. Maybe not as much with estradiol as Premarin and Provera, or estradiol or taking estradiol and progesterone, the actual thing, the actual hormone that your ovaries made for most of your life. But you don't want to wait until you already have coronary artery disease and start taking estrogens and progesterones, right? That just doesn't make sense. So you need to research this and decide, is this something for me? It will get rid of your hot flashes. Your skin will appear better. You won't look as old. I mean, I've done this for 30 years. Women on hormones do not look as old. They're more active. They have better bone strength. They have better muscle mass, especially if they're on testosterone. So make the decision early, around the age of 50, 51, 49. Don't wait till you're 55, 56. And get control of your insulin resistance, manage your other lifestyle options, lose weight if you need to do that. If anybody needs help doing that, that's what I do. I help you with lifestyle modifications so that you can remain youthful in your older age. So that's it for this morning. I will continue on this vein because I'm giving fourth module exams and final exams. I've got to do study guides for 4 different tests today. And part of what we're teaching in human anatomy and then in human physiology is the reproductive system. And unfortunately, it's always the last part of the semester, and it's the one I know the most about. So have a great day. I'm going to go change shirts because this is going to get too hot. I'll see you on Friday morning, if not tomorrow morning. I'm kind of staying at home right now, so have a great day. I'll talk to you later, either tomorrow or Friday. See ya. Bye.